welcome to this week's Crisis Learning Community Jam. And we're going to go back to a prior speaker today in John Franklin Sierra from the LA County Department of Mental Health. And look, I've loved this. We've always met a lot of folks in this field, but the collective impact, if you will, the community of innovators that is coming together and getting to know different people has really been terrific. And one of the concepts that we've continued to think about related to innovation and solving vexing, wicked problems is the idea of convergence. That we must bring in new ideas. We must cross-pollinate across different industries, different sectors, different disciplines. And this systems engineering approach that John brings by background is just been terrific. So we're looking forward to drilling down a little further into the work that he first raised with this group 3 months ago. We're also closing in on 1 year to the launch of 988. We're just a couple of weeks away from that. So Karen, let's go to the next slide. And I see Representative Orwell from the hot state of Washington State. So I was in Santa Fe over the weekend, actually, with John Draper, Sally Spencer-Thomas, and Eduardo Vega, and it was rainy and cool. And here in Arizona, it's hot, but not as hot as those of you up there in Oregon and Washington State. We're thrilled to have Medicaid leadership from Washington State having joined alongside behavioral health leadership, and we've sort of stalled a little bit at 7 states. If you're a Medicaid leader from one of the states in green, let us know. We'd like to change the color on the map. And if you're a Medicaid leader not on this call, please join us. We'd love to close the gap on some of these other states, especially as we talk about the mobile crisis and home and community-based services, FMAP increases, and other opportunities. As well, if you're a national organization and you're not represented in the list on the left, please let us know. We had actually, it says 255. I should update that. We broke another record last week. We had 272 of you joining us last week. And again, if you're in this call and you didn't receive an email about it, then let me know and we'll add you to our mailing list. In fact, I actually haven't sent out today's presentation yet. I'll do that afterward. But if you're not on the regular mailing list, let us know. Karen, next slide, please. And again, we're continuing. If you miss a Crisis Jam and want to see what went on, if you go to talk.crisisnow.com, the Learning Community tab in the upper right takes you to the videos of these calls. And there's also, if you see the link here, the presentations, the quotes, the tools, and other materials are there, as well as the terrific articles from our Crisis Talk editor, Stephanie Hepburn. Next slide, Karen. And this week's article, I think, is really a terrific one. And one of the elements around the Crisis Now model and the SAMHSA guidelines that comes up a lot is to what extent are these resources currently being deployed anywhere for children and adolescents? And as we think about the continuum of care for adolescents, are there other solutions that may need to come into scope? And Stephanie, you and I ran into a leader actually it was in the Netherlands, who was doing something similar to this. So this concept of in-home crisis stabilization is an international one. And this week, Stephanie, you talked to Andrea Rifkin.
That's right. And yeah, and it's a concept that isn't new either. I think it's, as you're stating, communities are trying to figure out how to fill in the gaps, and they're seeing a lot of default to hospitalization, just like you do with adults, except kids, for some reason, are staying there for longer periods of time. I interviewed Raina and her mother, Kana, and Raina spent 2.5 days in the emergency room waiting for hospitalization. So, actually, Kana is the person who introduced me to Andrea Rifkin. She's the program director at Shepherd Pratt Health Systems Care and Connection for Families in Montgomery County, Maryland. And she talks about the program does in-home stabilization for young people ages 6 to 18, I believe. And she talks about how it's able to divert and also be a step down from hospitalization and the gap that it fills. And she was talking about 988 and how vital it is as states start to think about the crisis system that kids don't get lost, and how vital it is for in-home stabilization to be part of that dialogue and considered in the plan as states build out their systems. She talked about COVID too, and that while the average client at present is middle schoolers 13 to 14, in recent months, she said the in-home stabilization programs experienced a spike in referrals for elementary school students who are expressing suicidal ideation. And here's a quote from her that I think really hits the nail on the head in terms of her thoughts in terms of in-home stabilization. She said, kids are hospitalized for long periods, and that means they lose access to their education and peers. In-home stabilization programs don't remove kids from their lives. We help them feel stronger and increase resilience. If Andrea's here, it'd be great to get some of her thoughts on the article as well.
Hi there, and thank you for having me and bringing attention to our program. We are very busy, and I think that, we're really seeing the stress and struggle of kids and families coming out of this pandemic and the continuation of the pandemic, frankly. And certainly open to any questions anyone has. We continue to grow our program, and we expect soon to be able to add more staff to our program and to continue to see more youth. At some point, we are hoping to expand either to the younger end of the spectrum or the older end of the spectrum, and even increase the ages that we're able to serve in the community. We've seen youth and their families throughout the pandemic face to face. We've been using outdoor spaces to do that because we feel so strongly that these kids need to be seen in their environment and have that face-to-face experience, especially being disconnected and alienated from their sources of support for so long. And I'm just excited to be here and to be part of the dialogue. So thank you so much for inviting me and for taking the time to talk to me about our program.
Andrea, thanks so much for the work that you're doing and for sharing with us today and with Stephanie. Stephanie, could you talk a little bit about the differences in the program we talked about this week and the program from the Netherlands that you referenced?
I think they're similar. I think the other program really can be activated immediately, and I think Andrea's program can as well, but there's more of a distinction, I think, between, if I'm understanding correctly, a mobile crisis response and in-home stabilization here versus, I think it's kind of used in lieu of mobile crisis in the Netherlands.
Yeah, it felt like Netherlands was a straight up mobile crisis extended into what Andrea is talking about. So a little bit of a hybrid of the two. So
but I think there's a variety. I think each country and each community is doing their own interpretation of that particular model.
But this concept of, given the lack of some of the resources that we've talked about in these forums of mobile crisis services and crisis receiving facilities, these types of programs, I think, are going to be ones that, especially for children and adolescents, are continue to be talked about. So great stuff. Stephanie, thanks for joining us. Andrea, Karen, let's go to the next slide. NAMI put on this terrific Wellbeing Trust and NAMI, as well as, oh gosh, Angela, I don't know if you're on the call. Angela, are you with us?
She's on vacation.
Okay, great, Andrew. How many organizations were part of the CEO Leadership Dialogue this past week?
9, I think. I wasn't a part of it. It was 9, I think.
It seemed like there were about 50 or 60, but
oh, I'm sorry. Yeah, you're probably right.
It was a terrific meeting around crisis and 988. And Tyler Norris from Wellbeing Trust, again, it sounds a little bit like collective impact, but a little bit more intentional about it. He called it a movement rooted in distributive action. So it's certainly the efforts that we're seeing along many different lanes as groups of stakeholders are coming together to support and ensure that we have the resourcing and strategic and political will to keep moving down this path. So thanks to Tyler Norris for driving that direction. Next slide, Karen. I believe Dr. Everett is not available to join us today, but John, I believe you were going to give an update to start us relative to SAMHSA.
Yeah, thank you, David. Yeah, Dr. Everett's away today, but she wanted me to pass on a couple of updates from SAMHSA, and I think Richard might have some additional information as well. Just wanted everyone to know that our new Assistant Secretary was confirmed, Dr. Miriam Delphin-Rittman. So she is now the Assistant Secretary at SAMHSA. And Tom Coderre, who had been the acting Assistant Secretary, is now in an acting deputy role until a new deputy is selected. And also just to let people know that there's a tremendous amount of activity with respect to coordination and planning happening within SAMHSA, including articulation of a very detailed work plan that involves coordination across federal partners and also with external stakeholders. And there'll be a lot more communication about that activity moving forward.
Terrific, John. And John, we'd also ask if you would participate in the roundtable at the end again and just make a reflection on John Franklin Sierra's presentation, if you're game for that.
Yeah, of course, I'm happy to.
Terrific. Richard McKeon, Dr. McKeon, any comments or updates?
Yeah, so one of the updates I would like to give is that yesterday was the first meeting of the United States Department of Health and Human Services Behavioral Health Coordinating Committee, which was announced perhaps a month ago. The Behavioral Health Coordinating Committee is co-chaired by our new Assistant Secretary, who was in that role yesterday, Dr. Miriam Delphin-Rittman. And the other co-chair is the Assistant Secretary for Health, Rachel Levine. There are 5 working groups or subcommittees as part of the Behavioral Health Coordinating Committee. There's suicide prevention and crisis care is one of those committees. And that is co-chaired by SAMHSA and by CDC. There are also committees on overdose prevention, performance measurement data and evaluation, children and youth, and behavioral and physical health integration are the 5 work groups. And all of those will be convening their inaugural meetings in the month of July. I would just add that I think it was a very impressive inaugural meeting. The co-leads of these 5 different work groups, I would want to emphasize, are all HHS Optive leads. So this process is engaging the leads from the National Institute of Health, of CDC, of FDA, of the Center for Medicare and Medicare Services, et cetera. So this is a very high level working group. And I'll just end my comments here by saying that, and it was overseen by Secretary Becerra. And in his closing comments, he mentioned several things. But one of the things that he did was to point to the unique importance of 988 as part of this process. And 988 is one of the areas to be focused on by the Suicide Prevention and Crisis Care group. But I think it was very clear that 988 was very much front of mind for Secretary Becerra, on this. So I think that's important for folks to be, to be aware of. So I will stop there. Thanks for the opportunity, David.
Oh, terrific, Richard. And Richard, it's only been 5 or 6 years ago that it continuously felt behavioral health and suicide prevention and crisis was in a silo to itself. And that really started to shift. And now to hear the interdepartmental approach that you're talking about and the whole of government coming together and the leadership from Becerra and continued throughout is tremendous. Really great update. Thanks so much. Next slide, Karen. Brian Hepburn, I know that in addition to the update on the states, you also are going to have Aaron give a quick update on the peer legislation that is moving forward.
Yeah, thank you, David. And thank you to you and to Richard and John SAMHSA for all the support. And as you said, a lot of moving parts as we move forward post-COVID. I want to quickly pass over to Aaron to talk about the PEERS Act, which is promoting and empowering effective recovery services. And that is for the beneficiaries of Medicare. But before I do, I just want to wish you and the group a happy 4th of July weekend. And I hope everybody rests and then comes back because ready to work, because we've got a year to really get the act together. So Aaron, do you want to go ahead?
Sure. Thank you, Brian. Excuse me. Yeah, this the PEERS Act has been something that NASHBID has been really advocating and working on, along with Mental Health America, the Depression and Bipolar Support Alliance, the National Association of Peer Supporters, and Association of Behavioral Health and Wellness. It was introduced into the Senate last week by Senators Catherine Cortez Masto and Bill Cassidy, and the number for that is S2144. And actually was introduced in the House side last year, but was reintroduced again this year by Representatives Judy Chu and Adrian Smith. And the House number on that is HR 2767. And basically this bill looks at specifying that peer support specialists may be billed under the collaborative care codes, as well as other behavioral health integration codes, which are very important. And so we're hoping to get this across the finish line hopefully this year, and definitely we'll update you as that comes across. And feel free to send out any questions if anyone has any, reach out to me. And I'll turn it back over to you, Brian.
And I'll turn it back over to David. Thank you very much and have a happy 4th of July, everybody.
Oh, terrific, Brian. And thank you, Aaron, for the update on the peer legislation. We did get a formal email from Jess Stolman Rainey about the work that she referenced in last week's chat. So we'll get that queued up into our pipeline of presentations. And Brian, for those counting at home, that's 3 weeks in a row. Brian has referenced the post-COVID strategy as we begin to pivot. So that's all great news. And thanks for the July 4th best wishes. Next slide, Karen. So Sarah Corcoran, we've been talking about the tsunami, and twice in the last week, I've heard I've heard from Tom Insel, and also heard from the leadership at Wellbeing Trust talking about 988 as a Trojan horse opportunity. Richard, you've said it differently, around once in a lifetime opportunity for transformation. But Sarah, what's the latest on the national front?
Yeah, so the infrastructure deal that I'm sure everyone has heard back and forth about, the evolving conversations there, seems to be reached among a bipartisan group of senators as well as the administration. That is more on the physical traditional infrastructure framework at about $500 to $600 million. We're still looking like the Senate Democrats and the administration will pursue a further infrastructure plan through the reconciliation process, which would lower that voting threshold in the Senate to being a simple majority, 50 plus the vice president's tie-breaking vote. That one is the one that will likely be a bigger package that will have some healthcare infrastructure elements to it. So we're really keeping a close eye on how those budget discussions evolve. In next week, the House Labor HHS Subcommittee will have the markup for the FY22 appropriations bill. That will give us a good idea about where the funding levels are set, as well as the priorities that have gotten funded in the House side. The Senate is pretty far behind in this process, but we'll be able to hopefully see some documentation sometime mid next week in advance of that hearing to get a better idea of what exactly FY22 should look like from the House's perspective. Finally, recess began for the Senate last week and the House this week. So it'll be a couple weeks of a bit of breathing time for the Hill. We're hoping once they come back all rested, just like all of us, we'll start to see things kind of quickly get into motion, and we'll have more information about how the rest of the summer, which looks to be pretty busy, will exactly unfold.
Terrific, Sarah. Thanks so much for that update. And before we go to AFSP, I want to just tee up in the crisis calculator section this week. Paul Galdus is on vacation, and Tom has presented various components of this health, home and community-based services FMAP increases the last few weeks. What I'd like to do today is take 5 seconds for him to address any questions or thoughts that you have around that home and community-based services, that enormous opportunity that is there. So we'll go to AFSP, and then we'll go to the states where we have legislation update, and then we'll come to Tom. So if you want to go ahead and put your questions or thoughts or reflections on that home and community-based services opportunity that we've been talking about, put that in the text. And Tom, if you can be tracking those, and let's see what dialogue that brings up for that section. So Connor, are you with us again today, or do we pivot to Taylor and Natalie today? Connor, are you with us? If not, Taylor or Natalie, are you guys with us?
This is Taylor. Connor should be with us because he's not done yet, but I don't know if he's on. And Natalie's actually out today, so I don't know that we have any updates for you today, but next week it should be Natalie and me will be on.
Terrific. So Karen, if you could just advance forward through the AFSP legislation tracking updates, and Taylor, we'll look forward to engaging you this coming time. So let's go to Laura and Angela. And actually, Andrew already referenced that Angela's not with us today, but Laura, I did pivot to the NAMI tracking tool as opposed to the one that we've been using. And we'll continue to think this through. The document that you've shared around some of the tracking efforts that Lifeline is engaged in, looking at the specific amounts of funding that are being put forth, and that really our best efforts to begin to track the progress on this. So Laura, any updates on what's happening at the state level?
Yes, thanks, David. And I'm going to keep my video off to save some bandwidth here. But the latest update is that the Colorado legislation has become a law officially. So that state will is colored here as being passed. It does have a user fee, which will be set by the board for their 988 enterprise. We are still awaiting New York signature for their legislation, and Massachusetts has scheduled a hearing July 19th to talk through their 988 legislation. So activity is slowing in the states, but not completely stopped.
And Laura, what happened with the California legislation? Where is that at?
So that is now in the Senate. So it's in its second chamber. The hearing has not been scheduled, but I do believe that they have language that will be added back into the bill. And we are very hopeful. I know there's some negotiations still going on in California, but hopeful that all parties will be able to get something over gold.
Terrific.
Hi. Sorry to interrupt. This is Tara Gamboa Eastman with the Steinberg Institute. We're working on the California legislation. So a quick update. We are not scheduled for a hearing yet, but we're hoping for the 6th and the 14th. And the language just went into print last week, so I'll drop that in the chat. Thanks so much.
Wonderful. Thanks so much, Tara. I really appreciate you jumping in. And Laura, changing to this map and continuing to think through, in the ideal world, what we're measuring is the amount of funding and resource required to fuel both 988 and a core continuum of crisis services, mobile crisis and crisis receiving, and the resources that are coming forth to meet that need. And you've begun tracking that and working with you and NAMI. Let's over the summer, let's see if we can't get a map that takes us to the next level in monitoring how far how far we've come and how far we yet need to go.
Yeah, absolutely, David. I think this we've been focusing on 988 legislation and a user fee, but certainly there are other states who have been going through their normal budgeting process and allocating funding for crisis centers and for the other components. So looking forward to having a map that kind of outlines all of those and is very easy to understand. So tall order.
Yeah, you know, and I don't, maybe it's not one map. I don't know. It's a little complex. Arizona has no legislation coming forth yet. On the other hand, we have 170 million in Medicaid and state dollars that are coming to a full continuum of crisis care. So, you know, Utah did not bring a fee, but they brought substantial funding to the table. So we're just going to have to keep pushing on this to try to reflect that. And I really appreciate your leadership and that of NAMI in helping us get there. So the other Representative Orwall, you mentioned the heat up there in Oregon and Washington State. The law has passed. The governor signed it. What's the status of where are you at now? What are the next steps?
Well, thank you so much for checking in. So our steering committee, which is really going to get all the planning up and running, should be meeting in mid-July. We'll be appointing, the governor's office will be appointing what we're calling the CRIS committee, which will be a broad base of different people with lived experience, providers, government, and then we'll start creating our subcommittees. There's a lot of work to be done, as you know, and one of the first things we'll be working on is that 988, 911 EMS law enforcement coordination. How are we all going to work together? What does that look like? Luckily, we put aside a significant training dollars so that we can develop trainings, and certainly looking at the national level for guidance.
Well, terrific. And the presentation from John Franklin Sierra today is going to be right up your alley, because the work that LA County has already been doing to bring a convergence and protocols has really been terrific. So great. Thank you so much for the update. And Karen mentioned to me that Rusha, your hand is up.
Hi, yeah, I just wanted to mention that in Oregon, our bill is at the governor's desk waiting to be passed. There was some funding associated with the bill for call centers and also for mobile crisis teams and services. And there also has been some additional bills that focused on the children's system and the mobile response stabilization services system that will also be part of the overall 988 and the crisis services system. And in addition, there are other pots of money, which are a combination of ARPA funds as well as TAPE dollars that will help us put together some demonstration sites for crisis stabilization centers. And then there is requirement for a report and a study, which will help legislators revisit the conversation around sustainable funding, whether it is through any kind of fees or not, but identifying the resource needs for sustainability.
Terrific. Rusha, thanks so much for the update. And we'll keep tracking this and looking to work with Laura and company with Angela Kimball and NAMI to figure out how to make these maps more complex and still simply following the progress. So great stuff. Next slide, Karen. So Tom Betlock, any questions or comments come in the chat related to home and community-based services or comments you want to make? I know we've hit this hard the last few weeks.
We have, David, so nothing really new to add. There weren't any specific questions. Mary Gilberty did raise some new legislation that has been introduced at the federal level to extend HCBS increased funding. So she provided that link. Haven't had a chance to take a look at that. And this is also a topic that's been included in the infrastructure side of things. So we'll have to track sort of the second infrastructure bill to see if there's progress there. The other thing is states are in the process of finalizing plans. And so look for those to be published by your state in terms of what they're looking to do with their increased HCBS funding. And they're going to be very high level in many instances. So for example, I'll post a link to Massachusetts. They've simply identified 3 big buckets that they'd like to target the money towards: workforce, expanded capacity, and technology. And then there's a lot of detail, I think, yet to be worked out at the state level. So just because we may not see crisis specifically listed, if you see expanded capacity, there may be opportunities to talk about how crisis fits in that. So we're still in the very early stages of the HCBS planning, but start to look for those details in your state.
So Tom, there is a question from Preston here, wondering about the new funding regarding HCBS. What specific crisis services are eligible for this pot of funding? From what I've understood from you so far, depending on how the state outlines, they could be fueling all three of the core components.
Yes, they can. So the state has, the money's really fungible, right? So the state has the increased funding that they need to push out. That's as a result of the increased HCBS funding, and HCBS again includes the rehab option for behavioral health services. And so in CMS's guidance to states, they have said expanding behavioral health capacity is one of the areas that can be viewed as an investment. So to me, that says that CMS will accept states wanting to move on all three components of the Crisis Now model. And so states could look to target resources to expanding all three areas of the crisis continuum.
Tom, we've talked about it. You've updated us that the amount of Medicaid and other dollars coming to crisis in Arizona is upwards of 170 million. But it sounds like even in Arizona, what I'm hearing is there's expanded opportunities by virtue of this and other funding that's already coming into play.
Yeah, and talking with providers and others, and I think state officials have said this in some of the public presentations they've done. We touched on this earlier in the conversation today, that oftentimes as states have evolved crisis, there tends to be, I think, more of a focus on the adult population, less of a focus on kids. And I think you're going to hear from state leaders in Arizona look to potentially avail the opportunity of the HCBS funding to develop new crisis infrastructure for children in Arizona. So I would expect the state to be looking at that as an option in terms of an investment area.
And Tom, last thing, I know states are vary dramatically from managed care to fee for service, et cetera, but I always think it's eye-opening when you talk about the specific crisis capitation PMPM that Arizona has. Can you just briefly tee that up again for folks to understand how we've gotten to this level of investment?
Yeah, David, and we can touch on it in more detail at another meeting and actually bring in some of the documentation to help sort of guide the conversation. But, Arizona is a managed care state. It has a managed care organization that's responsible in each of the three regions. And then they're capitated on the entire Medicaid population for that region to develop the crisis infrastructure. So it's a very unique funding structure to have capitation going directly to the managed care organization specifically for adult and children's crisis services. And it gives it really a level of importance, I think, in terms of saying to the managed care organization, not only is crisis something that we view of value in Arizona, but we're gonna provide you resources specifically just for crisis services, and we'll be tracking the utilization of that and the outcomes associated with that. But it's a per member per month for all of the Medicaid members within that region that managed care organization receives, and it's for the crisis services.
Terrific. Thanks so much, Tom, and really appreciate your continued support and consulting and thought leadership in this area. I do see from Beck Whipple in the text commenting on these. What are these three core areas? So just again, think about the building blocks here. We're obviously talking about 988 and the state and sub-state regional crisis call centers that are supporting that effort. In addition to those, think about a parity to the emergency medical response system. We've got 911 ambulances and hospital emergency departments for treatment and triage. We've got the same thing in the core elements of crisis, the call hubs, the mobile teams that will go to you, and then those facilities that someone can go to. Those are all articulated in great degree in SAMHSA's national guidelines for behavioral health crisis care, as well as the crisisnow.com website that NASHBIT and other partners push forward. The National Action Alliance Crisis Now policy document also goes into a great amount of detail about those components. And then there are other elements of a broader continuum. And today we talked about in-home stabilization, so peer crisis respite, and a host of other resources that communities might bring to bear to augment and support those core elements. So we'll keep talking about all of that as we go forward. Karen, let's go all the way through to the first slide. We'll skip the 5 questions and the detail there. So this idea of systems engineering, and organization, flow, patterns and pathways. John Franklin Sierra, the first time you presented to us three months ago, you were talking about this quote, every system gives the outcomes that it is perfectly designed to achieve. Really loved seeing where you've gone and continuously evolving those you gave us sort of the current state in that last meeting, but the future state that you're beginning to outline and crosswalking that to the framework that Captain Gannon brought us. Love for you to go into more depth today.
Thanks, David. Can everybody hear me?
Yes.
Awesome. Briefly again, my name is John Franklin Sierra. I'm a senior analyst at the LA County Department of Mental Health. Just quick background on where we sit within this whole conversation, our department. In California, all of the public specialty mental health services, including crisis mental health services, are carved out to county-based mental health managed care plans. And so DMH, LA County DMH is the mental health managed care plan for LA County. And so we're responsible for organizing a network of providers for specialty mental health services for the state, and that includes crisis services. And so we're kind of a major funder, and then we also provide some of these services ourselves, most notably the mobile crisis services in the county. We actually provide ourselves. So LA County, largest county in the US by population, not the largest by geography, but still pretty big by geography as well, with actually a really interesting mix of both very urban and very rural environments. And so we have kind of the whole spectrum of need and challenges here in LA County. And it's been interesting trying to figure out how to solve this problem. But as David mentioned, so my background is actually, I'm not a clinician. I'm an industrial and systems engineer by training, and studied that in the context of healthcare for a very long time. But that's kind of the lens that I've tried to bring to this conversation of how we can improve crisis response services across LA County. And, we've been having these conversations for several months now, where we looped in our law enforcement partners, our fire department EMS partners, different community care providers and crisis care providers, our 988 provider. We've put out a number of reports so far. This is the latest public one from March. I was actually hoping to have the most recent update for you ready to share in a link. It's not quite out yet, but I'll be able to share that soon. And it'll include some of the diagrams that you'll see on screen soon here. But, we've been having these conversations for a while and trying to iron out, what are some of our key priorities for crisis reform in LA County? We have a lot of the constituent elements, like we have mobile crisis teams, nowhere near enough, but we have some. We have crisis receiving facilities, again, not enough, but we have some, as you can see on screen. This is a map of the what we call urgent care centers, mental health urgent care centers, but these are our crisis receiving 23-hour stabilization and observation units. And the blue around them is a 15-minute drive time radius. And so you can see we've got decent coverage, but there's still some notable gaps throughout the county where there are population centers not within 15 minutes of an urgent care center, right? And so, we have some of these pieces, but we need more of them, and they're also not as coordinated as they should be, and especially in the context of 988 coming live. And so one of the first priorities we really nailed on in our conversations with all of our partners is that, we really need to have, really take ownership of this idea that mental health and substance use crises are health emergencies, right? That these are, they need just as rapid and appropriately staffed and trained a response as other kinds of health emergencies. And to that end, 988, I think immediately when we talked about 988 with our law enforcement and fire partners, they're like, oh, like it's a 3-digit number that starts with a 9, right? I mean, this is going to be, the public is going to have certain expectations from 988, from a number like that, may differ slightly from the expectations they've had from the, standard National Suicide Prevention Lifeline number. And we need to think about that and think about the implications for the system. Folks are going to call 911 who probably should have called 988, and folks are going to call 988 who probably should have called 911. And so we really started talking about how do we figure out how to make a no wrong door for crisis services, a reality, and be able to coordinate the services coming out of 911 and 988 so that we can still get folks to the right response regardless of which one they call first, right? And that was a really important part of what we talked about. But also this idea of diversion from law enforcement response has been really core and central to our conversations from the beginning. In fact, it was the lead driver of these conversations about crisis system reform in LA County prior to us even knowing about 988 coming down the horizon, right? And so what we've really tried to do is say, how can we architect a system where it's clear that law enforcement are only being sent to mental health and substance use crises when there's an actual need for a law enforcement presence, a clear and reasonable need for a law enforcement presence. And then for everything else, we're diverting it. We're diverting it to civilian resources, right? And then we also talked about this idea that, you know, it has come up time and time again in our conversations with the community that they're looking for responses to mental health emergencies and substance use emergencies that are caring, with cultural understanding and humility of the community that they're responding to. Ideally, where the people responding are from that community or understand or know that community well, know the folks in that community, and you know, have that kind of a bit of trust that they can build from that, right? So we've, instead of, you know, right now we have a very centralized mobile response program that's just operated by our department. And we have talked about expanding that program to better meet the needs, but we've also said, you know, let's try working with some of our city partners who are interested in potentially starting up their own programs to make that work, right? Adding other programs like that, it creates challenges and potential fragmentation, right? But if we think about from the get-go how we could set that up and architect that so that it's coordinated, so that we're all at least on the same page and utilizing similar standards. The upside of that is that cities could feel more ownership over these programs, develop them a little more locally, again, ideally with staff who live in those communities, kind of similar to how our fire and EMS services are currently set up throughout the county, right? And so that's something that we've really been working with our city partners to try to figure out how we could make that work. And there are several cities that are in various stages of investigating setting up their own mobile crisis programs, to which we're also looking to, as the mental health plan for the county, see what we can do to leverage any cities that, you know, want to start their own programs, still use us to draw down federal match dollars through Medicaid, right? And then this last point is just like, you know, there's just a lot of trust issues that we hear from the community, right? Like a huge, like just emphasis on, I don't like calling 911. I don't trust 911 for my mental health emergencies. You know, I've heard so many horror stories and bad experiences. I know folks, or I even have family who have been killed by police, you know, in the course of responding to a mental health crisis. And we have to understand that. We have to understand where the community is coming from. And I think what we've tried to do is just use models like what you're seeing on the next page and actually show these models to the community and have really, you know, hard conversations with the community about them to say, like, look, this is where we're thinking. This is where we're at, you know, and what do you think and how do you respond to this? And so that transparency is something we've really tried to ingrain throughout this process of negotiation with the community, to try to build a shared understanding of the challenges here, and also to, you know, facilitate really like active listening with them. So I think the next slide is probably
so John, just
okay.
A couple of comments. This statement you used, only sending law enforcement when there's, quote, clear and reasonable cause, unquote. That I love that so much. And then the other things, caring, cultural humility, et cetera. But you started out mapping out your system on the right here, and then you and law enforcement began working together on this terrific triage set on the left.
Yep. Yeah. So so what you see on the left was, you know, again, these ideas of not whether it's coming into 911 or 988, we're going to triage the call appropriately, right? Like, and that means having shared standards for how 911 and 988 handle these calls to an extent, and having a shared language for how we classify calls that require different kinds of responses, right? So we actually worked with our law enforcement and law enforcement dispatch partners on what you see on the left, which is just an attempt to say, like, can we develop a set of like a set of standards for how we would classify calls, including at the highest level, those calls that we think need an actual law enforcement component in the response. Now, these are not representative of the proportionality of volume of calls we would expect. For those level 4 calls, we're really feeling like that's 5, maybe 10% of the behavioral health crisis calls that come into 911, probably even less of the crisis calls that come into 988. But they're there, and this has been one of those hardest conversations we've had to have with the community of like, look, like, we don't think this is a very high volume of these level 4 calls, but they do exist. Someone's on a bridge, someone is, threatening someone else with a gun. It happens, like it happens, and we have to find a way to, take that very seriously and still try to send behavioral health resources to those calls. What we've said is, ideally, we would want to be sending one of our co-response teams to those level 4 calls. Those are our like mental health and law enforcement collaboration teams that we have throughout the county. We still need more of those really to meet the need for level 4 calls, but we want behavioral health resources still responding in real time to these level 4 calls. But it's that still means law enforcement responding, and so we've had to be very transparent with the community about that. But then we've said the better we can do a job of clarifying these are the really truly level 4 calls, the more easily we can then clarify that everything else is not a level 4 call, right? That does not need law enforcement responding to it, and it can be a civilian response. We've proposed that level 3 would be calls that really need an in-person response. Level 2 are probably those calls that could be handled at our 988 call center over the phone or via chat or text. We have a little M there to signify, some of the, there are still emergent medical needs that come up in these calls that we need to account for and work with our EMS partners to identify, and so on. And so then what you see on the right is like a diagram we put together to try to understand the current system, and some of the spaghetti in the current system is what we would call it in the systems diagram, right? Like, you see a lot of these like tons and tons of lines coming out of the box in the upper left of 911 law enforcement PSAP, for instance. And like lots of lines is bad. That's just visually, like if you think about systems design, it's a representation of complexity and lack of workability. I mean, the implications of that box, for instance, is that under the current system, with some of the pilots we have going on, a 911 dispatcher would have to choose from one of 6 different options for where to triage a behavioral health crisis call. And that just really isn't realistic. And, and so we've talked about, okay, what would an ideal system look like? And really an ideal system, what we said is that, okay, a level 4 call probably needs to stay in the 911 system, have law enforcement work out the response, including a co-response. Same thing for the M calls. These are emergent medical presentations. They would stay in the 911 system, get routed to a fire department for an EMS response. But everything else, let's triage it over to the 988 side of things, right? And so essentially what we said is, by doing it this way, we hope we're only adding one more decision point essentially for 911 dispatchers. And we think that that's just going to be a lot more scalable and easily scalable, especially when you think of in LA County, we have nearly 80 911 call centers. And so, it's going to be a logistical challenge just implementing this across each of those, right? And so by saying, okay, we're only asking you to do one more thing, right? We're only asking you to make one more decision, route it over the 988 side. That's like one big thing that we've framed out here. And on the right, you can see it's color coded to match up to the colors on the left, right? And another big thing is that we've discussed, though, of course, is this idea that if we have multiple different mobile crisis programs, maybe that are city run, we have to be able to, connect with those programs as needed for a 988 caller or a 911 caller who needs an in-person response. And so looking at and investigating the possibility of, instead of having a centralized dispatch center for all mobile crisis in the county, having potentially some kind of a coordinated network of dispatch centers, using, again, shared standards, using the same technology for coordination of calls. And to that effect, one thing that we'd ideally be trying to do here, for those who don't know, within California, the 911 system uses a standard technology platform to connect all the 911 dispatch centers in the state, right? And so when they transfer a call from one 911 call center to another, it's actually pretty seamless. They just press a button and the other dispatch center comes on the line. So in LA County, that's how, for instance, a call to a 911 law enforcement dispatch center gets connected with a fire department dispatch center. They just press a button and there's clicks, fire department dispatchers on the line. That's it. And we want to try to achieve the same thing for 988, so that if they need to pull in the 988 call center, press a button, click, click. Okay, hey, I've got a mental health crisis counselor on the line. Let's start talking about this, right? That's how we feel we can kind of virtually co-locate essentially our 988 call center operations within the entire 911 network and achieve the kind of coordination that we're talking about.
John, one of the things you mentioned, if I understood it correctly, is when a PSAP talks to another PSAP through that process, the data is going along with that button push.
Correct. Yep, the data is going along with that button push. At least the data that comes in at the original call origination, if that dispatcher has taken any notes, that doesn't necessarily get transferred over, but that's why the way it usually works is they try to figure out within the first 10 seconds what kind of a call it is and just pull someone up on the line if needed, so that they're there right when the caller starts getting into talking about their needs in the presentation.
John, it's a simple thing, but you just gave it one sentence, and I'd like you to talk a little bit more, because I think functionally this is really going somewhere related to your comments earlier about a clear and reasonable use for law enforcement. Same thing for medical, but the color coding of this, you've got simpler lines, easier to predictably, functionally manage, but the color coding and the lines, the green and the black, just talk a little bit more about that if you would.
Yeah, so the color coding is just meant to match up to the grid on the left, right? So red is your level 4 calls that need to stay on the law enforcement side, but we've clearly said here we want co-response teams to be a part of that mix across the board. We want every level 4 call should get a co-response team responding to it, and plus additional patrol officers as needed, right? We still aren't even where we are there. So actually that's the thing, like part of this conversation has been with the community has been, we actually need more co-response teams too, which is a little counterintuitive and not what you guys have been saying, but is actually going to be really key to making the rest of this work, right? And then blue is, to match up with the M on that side. These are the calls that need to stay within the fire EMS side of things. One of the things though that we've really been working on is making a pilot program so that our EMS partners are able to transport to destinations other than hospitals. That's been one of the big limitations in our current system, is that they're required to transport clients to hospitals. We have a pilot program with our EMS agency where they're able to transport to alternative destinations like our crisis stabilization units. And then your orange though is your actual genuine mental health crisis side of things, right? And then the yellow is just signifying calls that stay at the call center level, right? So the right half of this is really just meant to be, how do we orchestrate this so that whenever possible, we're pushing calls toward the right, and away from law enforcement and EMS responses unless they're absolutely necessary. So we have decision points where we are making decisions like, yes, we're opting in. This is a call that actually does require law enforcement or EMS, and otherwise push it over, right? And that's kind of the green lines are meant to say like in order to achieve that in a system, David brought up that quote, right? Like every system is perfectly designed to get the results it gets. We say that because if you're trying to achieve an outcome like diversion of calls to civilian resources, you need to be able to see the design of that in your system. You need to be able to see it on paper like this, or it's not going to happen, right? Of course, then you also need to measure it to make sure it's actually happening, right? But you have to be able to get down to, how is my system designed to actually achieve this goal that I'm saying I'm achieving? And others on previous calls have brought up things like addressing inequities in the system and how you need to address those up front, or else they're just not going to happen automatically, right? It's the same idea here, that you have to design systems like this very explicitly to achieve the outcomes you're trying to get.
So John, I love this so much. And look, what you've said is that for 988 volume, we believe that 85 to 95% or greater will be in that orange, yellow, and green, and a smaller percent for those red. For 911, it may be higher, but it's going to be a similar dynamic there. And Ron Bruno, I don't know if you're on, but Ron, in September of 2019, you gave a presentation at the Crisis Now Summit in DC, and you laid out a philosophy that this feels like the next version of execution on. And Ron, are you on the line to make any comments to see if you agree with me on that? Ron may not be with us. Ron, jump in if you are. But hey, two other things that have come up in the text and chat area. John, do have to do with chat and text capabilities, and we're going to skip that for now. But I think that warrants a specific presentation. So I'll talk to John Draper and to others, and let's see if we can't do something related to those capabilities, because we are going to see those.
Briefly to that effect, we'd be looking to have that same kind of coordination between 911 and 988 around chat and text. That's a big part of the California's Next Gen 911 initiative, is enabling better chat and text 911 capabilities. And we'd be looking for the same interoperability and coordination with the 988 side of things for that.
Yeah, and then there's another question around language usage. Obviously, we have a high number of people in LA County who English is not their primary language, but we also have a deaf and hard of hearing population that, in terms of not just the calls, but chat and text, how does all that work? I think the deaf and hard of hearing Megan at NASBT has been talking about that population and prioritizing. I think maybe again, John, we had talked about a possible presentation on that topic. So Ron is not jumping in here. Ron may not be with us today, but John Palmieri with SAMHSA, I'd love to get just reflection or comment or question from you as we round up today's call.
Yeah, thanks, David. John, thank you so much for this presentation. I mean, it's extremely impressive in the way that you've applied an engineering lens to, reworking the sort of flow here. And I'm curious, just as a follow-up question, related to kind of systems engineering, what have you found to be challenges in terms of stuck points or rate limiting steps in kind of this rewiring process? And I'm thinking in particular about culture change and risk tolerance for stakeholders that may be used to working in a certain way and now sort of are being asked to work in a different way. And I'm curious as to your thoughts about that.
Oh gosh, I mean, there's a lot of that, right? I mean, even just this idea of mental health emergencies or health emergencies and deserve, the same kind of 24/7, 365 availability of response as other health emergencies. Not everybody in LA County is on board with that, right? I mean, that in and of itself is a big culture change. And, I think like, I don't know if engineering brings anything special to the table around getting through some of those culture change barriers and addressing cultural inertia in organizations, other than that it's known as a thing that you need to recognize up front. You need to be transparent about your goals and try to get them on paper, right? I mean, this is essentially a set of goals here in visual form, right? And so we use tools like this to try to just, check in with everybody, like, does this resonate? Does this make sense? And if so, now I hope you understand why we've identified a portfolio of work that's very specific to accomplishing this, right? And let's try to work through and understand that in order to get to this, which you agree makes sense, right? There's a bunch of changes we're going to have to make, right? And so I don't have it to share right now, but we actually have a whole project portfolio that we've essentially crafted based on what it would take to achieve this. And it's a lot of change that needs to happen in order to get here. But by using this and by clarifying these North Stars in, as simply as possible on paper, I think the hope is that we can, help with that cultural inertia.
Great question, John. Hey, Captain Gannon, were you able to join us? Do you know, John, if Captain Gannon is with us?
I'm not sure.
So I'm not hearing Captain Gannon jump in. And John, you did, he was a key partner on developing that framework on the left.
Yep.
Dr. Chuck, you have any comments or reflections? I know you've been enamored with this flow issues. So Dr. Chuck may not be with us either. So John, great work. We have had a request for these as standalone documents. So I will send those with your permission. We'll send these out, both the dispatch sort of stages criteria. I'll send that out, and these flow documents, as well as, again, we'll post those on the Crisis Talk website and share all these this information by email. And of course, John, your contact information, if it's okay, we'll share that with the group as well.
Yeah, here I'll post it in chat as well.
David, 30 seconds if I might.
Yeah, go ahead, Richard.
Yeah, so great work, John. Very impressive. I think this is the level of detail that's really needed. One, for information for folks on the group, SAMHSA has funded Vibrant to start a learning community around 988 or 911 change that with the supplement that they were awarded several weeks ago. And this looks like it's just a wonderful example. The other question would be, you just say a bit about your coordination with the Dee Dee Hirsch, who answers more Lifeline calls and presumably will answer more 988 calls than any other center in America other than the Veterans Crisis Line. So can you talk a little bit about how that's going?
Oh, yeah, they've been an integral partner, obviously, to this, right? And even just, you know, because as of right now, they answer mostly, it's National Suicide Prevention Lifeline calls. They're not necessarily getting, up until recently, they haven't been getting a lot of 911 type diverted behavioral health crisis calls, but they do actually have an active pilot with LAPD's 911 call center where they are diverting behavioral health crisis calls now 24 hours a day from that center. So they actually have an ongoing 911 diversion pilot, which is really great. They've been an integral partner. They are obviously they are our 988 call center for LA County. And they've been, you know, they've been a serious collaborator and even just envisioning this model and saying like, yeah, we think we can do this, right? Even for them though, it's going to be change, right? I mean, and it's a lot of change that they have to figure out how to assume this role and this responsibility as envisioned on this flow chart, but they've been just really excited about stepping up to the plate on that.
Thank you, John. Thank you, Richard. Karen, let's just go to the next slide and we'll close out for today. I think it's actually 2 more slides. So Margie's crisis memes. Margie, we've got your first in. We're going to need another one for next week, Margie. So the pressure's on now for us to keep up with the week to week. But Margie, any comment on this week's entry? Margie may have dropped off. Final slide, Karen, the flow for next week. We've got Whitney Bunce with the Center for Legal Action and Social Policy and discussion of mobile crisis. And she's going to lean into this co-responder discussion hard, John, based upon the paper that they put out this past year. And take a look. We've got the pipeline really filled out for the next few weeks. And we'll be putting some more in here. We've got several topics today. But again, if you have speakers or content that you think would be helpful to this group, please let us know. John, thanks again. Thanks to all of those of you who participated and hope to see you next week. Have a great July 4th. Bye-bye.